I'm going to give a brief introduction and then we'll dive in. As a reminder from the Office of the Medical Program Director, our vision is to provide consistent, high-quality emergency care to our patients when and where they need it most. And we're going to dive into what that looks like for a patient who may be suffering a stroke. So I'm going to review briefly the quality measures that we focus on as an EMS organization, and then we'll hear from our presenters. So in terms of EMS quality measures, key things that we follow for stroke are checking CBG. One of the mimics of stroke is hypoglycemia. It's one of the things we can treat in the field. And so before we spin up the entire stroke apparatus, we want to rule out hypoglycemia. The second key stroke measure is that patients that may be suffering from a stroke need a stroke exam. And so for us, that's BFAST as a broad screen for stroke, followed by LAMS to identify a large vessel occlusion. So how do we do on these measures right now? So if you look at non-transporting agencies, which understandably will not always be getting a CBG because sometimes the transporting agency is there first. Sometimes these things happen, transfer of care happens first, but we're pretty steady at around 75%. If with the primary impression of stroke, we document a CBG for a non-transporting agency. Transporting agency, obviously because our charts are linked, that flows from one end to the other, pretty steady at about 92%. And so this is something that we do well, we do consistently. I think we can push it a little higher, and I would love to get your ideas on how we can do that, how we can more reliably get the CBG documented, checked for patients that we identify as having a potential stroke. Feel free to message your training officers, you can put ideas into the chat, but I would love ideas on how we can just make this a little bit better. And then with stroke exam, transporting agencies, I bring this all together because if this is performed by the non-transporting agency, it comes into the transporting agency chart. We do fairly well. We're at around 97% at least some of the stroke exams documented. The biggest area where we could potentially improve is documenting the last known well, but we're also looking at ways to make that easier. We're trying to figure out if we can get an integration between Pulsara and ESO so that you're only having to document things once, because we want to make things this as easy and we want to make it flow as well as possible. So that is, with that brief introduction to the quality measures we focus on as the EMS group, I want to go into depth. So our first presenter is Dr. Rene Sanchez-Mejia. He's a neurointerventional doctor at Peace Health Southwest. And so I'll turn things over to him.
Good, thank you. So just come over to share my slides here.
Yep. And so what I'll stop.
So the focus of what I'll be talking about today is really something that I've heard just in my career from paramedics, both lecturing up to medic one in Seattle and when I was in San Diego, is that often you guys don't really know what happens to the patient once you drop them off in the emergency room. And so I'll focus on clinical examples of cases that kind of show the whole pathway to treatment. Let's see what this is working. I just do it here on the computer. Actually, this is Bluetooth, so I just do this. Yeah. So just a little bit about myself. Born in Los Angeles, Southern California. Did all my schooling in San Diego. Then went to Harvard for college and medical school. Before going back to California, I did my residency at UCSF, where I learned how to sail. And went back to Harvard for a fellowship in endovascular. And you'll see in some of these cases that we discussed today, we're going to discuss open surgical treatments as well as endovascular treatments. So I went back to do kind of a catheter-based endovascular training, and then had a practice at Scripps Clinic in La Jolla for about 10 years before coming up to Virginia Mason. And as also one of your colleagues decided to go to private practice, and now I'm in the Portland, Vancouver area. So when we look at integrative or comprehensive stroke management, we're really trying to achieve better outcomes. And we do that by endovascular treatments, which is a treatment modality that I mentioned, craniotomies and microsurgical techniques, which we'll go over. Radiosurgery is less of an acute issue, and then the neurocritical care management of the patient medically is really important. So when we look at strokes, we're looking at one of the leading causes of death and disability. So the third leading cause of death and the number one cause of major disability. And we're looking at about 1 million strokes in the United States per year. As you can see from that pie chart, the vast majority of strokes are ischemic, so 85%, and the rest, the hemorrhagic, are made up of either primary intracranial hemorrhage, which is hypertensive hemorrhage, aneurysms, which we'll go over, and these other vascular malformations. So as you know, you guys play a very critical role in the time management of this. It's very critical that we address any of these issues in a timely fashion. And so this quote of time equals brain is used in our field. And obviously that first step in this process is EMS and triage determination that it's likely a stroke. I think Pulsera has really revolutionized this. The other thing is we have our own metrics. Once a patient reaches the hospital, we need to do an assessment, get imaging within 40 minutes. And then IV TPA, which is the clot busting medication now, TNK is more commonly used, can be given up to 4.5 hours after last known well. Again, emphasizing the importance of knowing that time. And then intra-arterial TPA, so endovascular treatments, we can give TPA up to 6 hours. And then mechanical thrombectomies, where we physically remove the blood clot from the brain, has now extended that time window up to 24 hours. And really in select patients, so young patient that maybe we don't know the last known well, and we're even beyond 24 hours, is the imaging, which I'll go over, is promising. We often will intervene in those patients as well.
Dr. Sanchez,
Yeah.
real quick, sorry, we might have to pause for just a
Oh,
quick
sure.
second. You might have to, Rob's gonna share his screen.
Okay.
We've got roughly 35 people out there.
Oh, sure.
Yeah, they're watching, so just a quick little pause. Thank you.
No worries.
Sorry about the technical glitch.
No worries.
This is the revolutionizing of
Yeah.
presentations after COVID.
Right, fantastic, yeah. Share, so ours, you should just share your screen and then it should work out fine. And then pick his presentation.
Those are Microsoft Edge tabs. If you go to the window and pick the PowerPoint window.
Perfect.
So is this?
Yeah, should we get to go now?
Thank you.
Great. Everything's good.
Yeah.
Okay. Yeah. So the mechanical treatments, like I was saying, we go up to 24 hours, which is really kind of revolutionized stroke care. Again, that's in select patients. Not all patients can be treated in that time window. So when we think of, again, cerebrovascular disease or stroke, we're thinking of a vessel abnormality is the simplest way of dividing ischemic stroke from hemorrhagic. For ischemic, we're dealing with an issue of patency of the blood vessel, whether it's embolic, blood clot came from the heart from atrial fibrillation, whether it's thrombotic, so an in situ thrombus that forms in the artery, or whether we have a stenotic lesion and narrowing of the caliber of the artery. For hemorrhagic stroke, we're really talking about the integrity of the blood vessel. So one of the main causes of the integrity being compromised is an aneurysm, which is a balloon outpouching of the artery, an arterial venous malformation or AVM, which is an abnormal connection between the artery and the vein. And because the veins aren't designed for arterial pressures, they're prone to bursting. And then a dural arterial venous fistula, which is very similar to an AVM, but instead of being congenital, they're acquired. And all of these things can present in acute or non-acute fashion. Obviously, we're focused on the acute presentation. So why don't we talk about ischemic stroke first? As you know, we're wanting to diagnose the patients early, so there's a lot of community education so that patients will know that they're having a stroke. And we use the FAST acronym, facial, arm, speech, and then time to emphasize the timeliness of it. In certain places, maybe you guys can add this to your budget request for next year. There's ambulances with CT scanners where we can do a non-contrast head CT in the field, even do perfusion imaging in the field, so that when the patient's en route to the hospital, we already know that it's an ischemic versus hemorrhagic, and we're already getting the team activated for thrombectomy. So the importance of imaging is really to determine whether it's a hemorrhage or not, because the pathway is very different if the patient has an ischemic stroke We're trying to open up a blood vessel where someone has a hemorrhage, where they're bleeding out into their brain, and we want to lower blood pressure and do other things to mitigate that. And when we look at the other aspect of the imaging besides the hemorrhage, it's penumbra imaging. And penumbra is really the part of the brain that's getting inadequate blood flow, but has not yet died. And that is differentiated from the area in red that you see there, which is the core. That tissue's already been compromised, it's dead, but it's the tissue around it that we can try to salvage with either in any form of trying to reconstitute patency. And so we use CT perfusion. And again, you can see there in red, you have an area of infarct tissue that's already been lost, and in green, tissue that's still salvageable. And the reason we have a penumbra is because we have collateral blood vessels. So here, I don't really have a, actually I do have a pointer. Let's see here. So here you can see this middle cerebral artery is blocked, but the anterior cerebral arteries, which are from a different territory, are still giving blood flow to this penumbra. Not enough to make it functional tissue, so they're still going to have neurological deficits, but it's enough to keep that tissue alive to allow us that time window to intervene. This is a complete carotid occlusion, so nothing is flowing to that left hemisphere. This is after partial recanalization, which allows us to see those collateral vessels. And here, so here, I'll show you a video of one of the devices that we use. So here you see a thrombus, presumably from the heart, going up into the internal carotid artery and getting lodged in the middle cerebral artery, completely blocking flow, as you see on this angiogram, to that entire left hemisphere. And this is a device called a stent retriever. So we go into the femoral artery in the groin, navigate into the neck, go across the blood vessel with a microcatheter, and then you'll see the stent being deployed across the thrombus. The stent does two things. One, it reperfuses, so allows flow through the stent, which you'll see here, but it also enmeshes the thrombus, kind of grabs onto it, allowing us to pull it back. And in the neck and the carotid artery, there's a balloon catheter that we can inflate to arrest anterograde flow and pull that thrombus back into the guide catheter. So this is one of the mainstays of endovascular treatment. And then there's also aspiration devices where we can aspirate the clot, grab onto it, and pull it down. See if this stuff is still in there. So here's just an illustrative case, a young patient that had an ischemic stroke. She's a 42-year-old female, healthy smoker, lived alone with a newborn, and was going through a nasty custodial battle, divorce, was kind of chain smoking, is what she ended up telling us, and ended up going to sleep at around 10 o'clock the night before, when she woke up and called, well, she had called a friend the prior night. The following morning, she calls her mother, and all she can do on the phone is say, she keeps perseverating and saying babysitter over and over again. Mother lived in Michigan, called 911, and then paramedics came on the scene, where she was aphasic, perseverating, had dense right hemiplegia, severe neglect. And when she had her imaging performed, we can see that she had complete carotid occlusion in the neck. She also had a thrombus up in the brain. And here you see on her MRI, she had small little infarcts. Most of the tissue was still viable on that side. And so this is the actual procedure. You can see the carotid arteries occluded in the neck, no blood flow into the brain. Once I was able to open that up, you can see that she has thrombus in the brain as well. So this is a clot right there blocking that vessel. And then this is after the reperfusion. You can see the entire neck is open, the carotid circulation is open, and that middle cerebral artery is open as well. So at 3 weeks, she was almost normal, had mild intermittent speech hesitation, and at 3 months was completely normal. Again, prior to these thrombectomy procedures, a patient like this really had no other option and would have probably died or been left with permanent disability. Here's another case, a 26-year-old who was getting ready to go to work and collapsed in his driveway when he was getting into his car. He has a complete occlusion of the right middle cerebral artery, no flow at all to this right hemisphere. Perfusion imaging was stable, and this is after reperfusion and blood flow to that side. The reason I showed you this case is that even though we were able to salvage that tissue, there was already a large infarct. So on this head CT, normal brain tissue looks this kind of dark and lighter gray color. This darker gray here is dead tissue. And in young patients, because we're dealing with the cranium that's a fixed cavity, when that brain tissue starts to swell, you're at risk of developing herniation syndrome, which can become life-threatening. So another life-saving procedure that we do is a hemicraniectomy. where we remove a large cranial flap, store that in the freezer, allowing the brain to swell outward and away from the brainstem. And then when the swelling subsides, we can bring the patient back to replace the bone flap. That was this patient's complication from San Diego, ended up having a normal outcome with just a minimal numbness in his finger. So now we'll transition over to hemorrhagic stroke. Again, we're dealing with the integrity of the blood vessel. And let's see here. I'll just briefly go over this, but this was really revolutionized with the introduction of the microscope in the 1970s. First patient who had an aneurysm clip was in the 1930s out of Johns Hopkins. That Dr. Dandy published a series of 12 patients. All the patients died during this study, but he kind of showed what he did and what didn't work. And then now we really have revolutionized not only the microsurgical treatment, but also we have a lot of endovascular options that allow us to treat aneurysms. And here in this animation, you'll just see an aneurysm being treated with a stent in a minimally invasive fashion. So here's the aneurysm. We can deploy a microcatheter across that base of the aneurysm, deploy a stent across that base, and then enter the aneurysm with a separate microcatheter and introduce platinum coils into the aneurysm. So here you'll see the stent being deployed. This is what a stent looks like. By the way, these arteries are about 2 millimeters in size. When you see the surgical videos, you'll see how small they really are, and they're very, very thin. So very easy to rupture them either during a thrombectomy when we're trying to remove a blood clot or when we're treating an aneurysm like this. And then here shortly, you'll see another microcatheter going through these interstices of the stent into the aneurysm and then filling the aneurysm with coils, which essentially allow blood clot formation, and you'll get healing along the neck of the aneurysm. So this has really changed. Prior to really 1990, all patients required an open craniotomy, and now these aneurysms can be treated in this minimally invasive way. Here's just a clinical. Oh, sure.
But your presentation is not keeping up with Teams, so
Oh, okay.
I still on the second slide, so I don't know, something's wrong. Your other users aren't able to see that.
Okay.
I thought that was just lag on my side, but I see that in the chat that they're having.
Oh, that's too bad.
the same issues.
Sure.
There you go.
They can see it now.
I'm on that slide now.
Yeah. Maybe instead of just doing a presentation, we just leave it as a window.
Okay.
And then we'll just, next slide.
Okay. So here's just an example of a patient with an aneurysm. You can see it's circled there. Here's a side view. Patient presented with retroorbital headaches. Here you see the actual treatment. So put a microcatheter into the middle cerebral artery to deploy the stent across the aneurysm. Here the stent is deployed, going into the aneurysm with that microcatheter. And then, just go back one slide here. That's the first coil there. And then you can get these treatments where you have the aneurysm before, completely gone after. And these types of patients, this was an unruptured case, can go home the next morning. But there are cases where we can't do this treatment. This is an example of a 53-year-old, she's actually a nurse, collapsed while preparing dinner for her family. By the time she showed up to the hospital, completely comatose, had a blown and dilated pupil. And the reason for that is she had a large hemorrhage from this aneurysm into the temporal lobe. So she was herniating and pushing on her brainstem, which is what gives you that blown pupil. She had this tiny little aneurysm that caused that massive hemorrhage. So for a patient like this, if we treated them endovascularly, they'd be dead at the end of the procedure because we're not dealing with the compression of the brainstem. So she went emergently to surgery, had a large hemicraniectomy to relieve the pressure, and at the same time had that aneurysm clipped. And I'll show you a video here shortly of how that's done. And some patients say, well, I never want the open surgery. No one wants the open craniotomy, but sometimes it's absolutely necessary. So this is just showing what we use to do the microsurgical treatment. That's an aneurysm there on the left. And that aneurysm allows us to see microscopic substance tissue. This microscope is controlled with my mouth. So it has a mouthpiece that I can bite on and move the microscope with my head. And then the right foot controls the bipolar cautery, left foot controls the zoom and focus. And then you can have both of your hands in the surgical field. And also we can do angiograms with the microscope using a fluorescent dye, which you'll see here in a second.
Jack said no.
Oops. I think. Be careful that we're in this mode. Okay, so here's just the surgery in a cadaver, kind of showing how this is done. So here's an incision kind of behind the forehead from the ear to the midline. We pull the scalp forward, right underneath your scalp. Here's the temporalis muscle, which you use for chewing. So that's mobilized inferiorly. And then once we get intracranially and do the craniotomy, you see the orbital roof above the eye. This is the dura of the frontal lobe and the temporal lobe. And right underneath that bone is the eye there. So we open up down to what's called the superior orbital fissure, where the third nerve goes in. And then once we open the dura, come in with a microscope, this is the view that we get. So the carotid artery, middle cerebral artery coming out at us. That's the anterior cerebral, that's the optic nerve where all your vision is processed, the signals from your eye. The third nerve, which allows you to move your eye up, down immediately. So here's just a case of a patient who had previously been treated with endovascular coiling, had a big recurrence of the aneurysm. And so when we clip, we just put an aneurysm clip along the base of the aneurysm. And here in this video, you'll be able to see how that's done. Explain. Yep. So here, again, under the microscope, this is the frontal lobe here. That was a temporal lobe on the side. Because she had a prior hemorrhage, the frontal lobe is really adherent and scarred into the optic nerve. So that's being dissected away from the optic nerve. This is now the aneurysm coming, or sorry, the internal carotid artery coming in. This is the aneurysm here. And I'm separating the aneurysm from that third nerve. So this truly is microscopic. So this artery here is about 3 millimeters. That nerve is about 1 millimeter. And those little arachnoid membranes, which is called arachnoid because it looks like a spider web, are being kept there to kind of separate all the different, the aneurysm from all the critical structures. And that's really the most critical part of the procedure prior to placing the clip, to make sure that the aneurysm is completely free so that we can get the clip blades in at the base of the aneurysm without compromising all those critical structures. And the other thing you can see here, this yellow discoloration of the artery is calcium or atheroma. You can see the prior coils that were placed during the prior surgery. Some of them were actually out in the brain tissue. So again, really separating this aneurysm neck from all the other critical tissue. And you can see how translucent the arteries are in the brain. So very, very thin. You can see right through them. These little arteries are critical going to the brainstem. Those are on the order of about 50 microns. And I'm just cutting away some of the scar tissue here away from the dome of the aneurysm. And then here shortly, you'll see the aneurysm clip being placed. I'm right-handed, so my left hand always has a little bit of tremor, especially at the microscopic scale. So aneurysm clip is coming in here. I'm using what's called a fenestrated clip because of that calcium. I want a stronger clip, and we want to make sure that we don't have to replace it, because when you place a clip and have to take it off and put it on again, often a piece of that calcium will break off and go and cause a stroke. Also, during the surgery, we do neuromonitoring. So there's a neurophysiologist that has electrodes in the brain and the body, and they're measuring all of the motor pathways and all the sensory pathways coming back to the brain. So that's the first clip being placed there. There's still a little bit of a filling of the aneurysm here, which we'll treat with the second clip. And this is exactly where I showed you on that other diagram. So right above the eye, which is over here, and we're under the frontal lobe and the temporal lobe, kind of lifting them up out of the way to get in for this visualization. Here's a second clip being placed, and this is in real time. And then you'll see a fluorescent angiogram showing that there's no more filling of the aneurysm over here, and there's patency of all the normal anatomy. Just take a second here for that to play. So again, we inject a fluorescent dye into the patient, and we can get confirmation of good flow in all the normal arteries and no filling into the aneurysm. So this is the last case that I'll show of an arteriovenous malformation. This is a healthy 65-year-old avid runner found down by her husband at home. Or she was also preparing dinner. Yeah, I forgot that detail. Called 911. When she showed up to the emergency room, she already had the fixed and dilated pupils bilaterally, which is a pretty ominous sign. And the initial head CT showed this big hemorrhage, which is this white substance. That's what blood looks like on the head CT, pushing on her brainstem. And things look pretty ominous at this point. But typically what we like to do in an emergency like that is really do a decompression and see if the patient will show improvement. So that's the first thing that she had done. So big removal of the bone flap, really from the top of the vertex down to the skull base. And after doing this, the patient's pupils normalized and she actually started having some spontaneous movement. We gave her a couple more days and she actually started moving spontaneously and following commands. So even though some of these patients that you guys see in the field look like they're dead or close to dead, often with the early intervention, they can improve dramatically. So this is what an AVM is. Again, abnormal connection between arteries and veins, and those veins that are designed for pressures of 20 are being fed blood flow at pressures of 150 or so, and they're just not designed for that. And so you get these large venous varices, and this is just the angiogram showing those abnormal connections. We have new tools for embolization, these liquid glue embolics that allow us to really penetrate into the AVM, as opposed to what we had before with those coils and particles that slow down flow to the AVM but don't really get in there and penetrate it. So she underwent several embolizations with this glue. Again, you can see her big cranial defect there from her initial craniectomy. And she had multiple branches that we needed to embolize. And then this is the AVM being resected. So that glue is actually this bluish substance. These are the main feeders coming in. There's one feeder there that I still haven't treated with embolization because I had access to it during surgery. And when we're removing these AVMs, it's kind of like a bomb. You have to go very sequentially, remove all the arterial input, the high pressure input. And then when you're done with that, then you remove the venous output. If you inadvertently damage the venous output before the arterial input goes in, it essentially ruptures intraoperatively. And so here I'm just separating the AVM from the surrounding tissue, which is not normal looking because of the hemorrhage, very, very swollen looking. And I come across these branches that I've already embolized, again, making the surgery significantly safer. And we'll cut that here in a second. And once you've circumferentially gone around the entire AVM in 3 dimensions, both the deep and all the other sides, then we can place a clip across the vein. We're not expecting any problems here because we've already removed all the arterial inputs. There's no hemorrhage, and then we can cut across that vein. And this is the dura, or the leathery covering around the brain, where that that vein drains into. And then here you'll see the AVM being removed. So this is the AVM there. And you'll be able to see the undersurface and those branches that we embolized with that glue. I'll show you the AVM here. So we can look at all sides of that AVM, which caused that hemorrhage. I'll just move on. So this patient ended up having a very good outcome. This is her angiogram. Again, the AVM before the surgery, it's gone after the surgery. And I mentioned she was an avid runner in San Diego. We had this rock and roll half marathon that she ran again. So again, better outcomes by combining all these different modalities. And this is really just to show you guys that the patient that you pick up from home or elsewhere, once they get to the hospital, these are the things that you're delivering the patient to. And it's really essential. Everything that you guys do, really appreciate all the information you guys are providing on Pulsera. It really allows us to pivot and plan our treatments. Thank you. And if you have any questions.
And Mark, any questions on that?
I have no questions on that.
Okay. And I guess with the patients that are potentially treatable, like, are there certain presentations that are easier to miss than others? Or
Not really. I think it's hard to know. I think if you have a young patient that maybe is using meth or something like that, it's probably more likely to be a hemorrhagic stroke. But it's hard to tell based on neurological deficits alone, whether it's ischemic or hemorrhagic. I think the things that you mentioned of the physical exam that you guys document is really important. And then some of those scales don't tell us like about the leg, it's the face and the arm. The more information that we have, the better. And I actually, get the first notification because I like to know what you guys are seeing in the field. And that allows us to start mobilizing the team If it's a young patient, it's around 4 or 5. We pretty much, know that it's going to be an intervention if it's ischemic, and that just helps kind of coordinate the care in our setting. So,
Thank you.
Yeah, excellent. Quick question, and maybe this is more.
Thank you. I'm trying to-
What?
Go ahead.
Oh, are you guys fully staffed now?
Yes, and I will talk more about that in my presentation.
Okay, fantastic. Thank you very much.
you're welcome.
Did you have a question?
I do, yeah. From where you stand with your job and everything, and us on the EMS side of everything, there's a lot of boxes that we have to kind of check, So as far as us wanting to bring a patient in, 12 lead done, large enough bore IV in the right place and all that, sometimes we can end up wanting to get all of those boxes clicked and end up sitting on scene longer.
Right.
Where do you see the balance in that as far as we're having trouble getting an IV? We don't, sometimes the people want to get their 12 lead when we're not moving. So, but would you rather bring people in with that stuff? I know that it's kind of an unanswerable question, but like, where's the line?
I think time is number one. So I think getting in faster is going to trump all those other things. And, often, the large bore is, obviously for resuscitation, but also for the CT perfusion study, we need that to give the contrast. But in the hospital, you have a team of nurses that are with the patient when they're going to CT scan. And so, there's more resources than you guys are going to have in the field. So I would say that the time is more important than getting all those boxes checked.
Okay.
Yeah.
Okay, thank you. And I would just add on to that. The reason that the things that we track are the blood glucose and the stroke exam. Those are the things that matter, and the rest can't happen on the way. The rest doesn't need to delay care. We just need to identify cases with a complete should be intervened on. We need to rule out hypoglycemia. For the 12 week for a stroke patient is not a time sensitive intervention. Okay, maybe just a second. I'm going to bring Candace's slides up.
I guess I can start by just introducing myself so we can save some time. My name is Candace Oki. I am the stroke navigator at PCEP Southwest. I love your presentation, Dr. Sanchez, because it lays out pretty much what everything I was going to say, so it works out very well. Some background about my experience. I've been a nurse for just under 10 years now. I started in Las Vegas, actually. I was born and raised there. I graduated nursing school and I worked in the middle of the city at the Level 1 Trauma Center for the last 7 years before I moved up here. So gunshots, stab wounds, strokes. I worked in a chest pain center, STEMI certified center, you name it. We saw it. So I worked on the floor. We would float down to the ED all the time. I have a massive appreciation for what you guys do because it truly makes a difference in terms of getting your patients in, getting the correct interventions. So hopefully do best by our patients. So, yeah. While we're getting that up, my presentation is about Pulsera and the patient flow at Peace Health. Does anybody have any qualms or questions about Pulsera? I know it's kind of a silly opening introductory question. Some people really, really like it. Some people think it's kind of a redundant thing. Let's talk about it. How do you feel about Pulsera?
It does feel a bit redundant sometimes, especially with limited resources on the team.
Okay.
We're taking some personnel that could possibly be providing care to enter data entry for us.
Makes sense. Are you guys still doing like a radio report as well as a Pulsera entry, or do you guys use like a different system out here? I come from the land of radio report, so.
It's my experience recently has been if Pulsera isn't working for some reason, default back to a radio or phone report. But
Cool. All right, good to know.
Okay, if I jump in, like, I'm very sensitive to that, like the workflow issue on that, and that's why we're investigating and Fire District 3 is trialing integration between Pulsara and ESO, because if the documentation can't start on Pulsara, but that's also filling all your ESO requirements at the same time, then we want to free up hands to take care of the patient. So I'm very sensitive to that, and we're trying to build a better system and doing some small scale trials to see how we can make that work.
And relation to the comment that was made earlier about like your 12 lead and stuff like that, I know Pulsera also has capabilities to sync to like a Zoll as well. So if you hook your patient up to a Zoll monitor, it can record your 12 lead and it can be sent in that way. So there's certain ways that you can integrate different portions of your care on the field to where we can see it without you having to do like 3 things at once, if that makes sense. So
Yeah, we use Stryker monitors, but Stryker is in talks with Pulsara to develop an
yeah,
innovation.
so there's a lot of cool stuff coming our way with Pulsera. So let's see, workflow. This is a very convoluted chart. It's very long. It has a lot of boxes. Not a lot of people like Venn diagrams, but I think this is the best way to kind of show. I know it's really small, so it's hard to see. That being said, I'll just walk you guys through it because it all starts with you. EMS-wise, you guys are going to create that patient channel in Pulsera. You're going to send us that basic information, right? Patient name, date of birth, age, gender. Like Marlon said before, the one thing that we are hoping to see more of with that general information is that last known well time, because that is something that is going to determine the interventions that we can provide our patients. Whether we're going to end up with like a TNK for severe large vessel occlusion, or they're 19 hours out from their last known well and we're going to take them to see Dr. Sanchez in the cath lab. That field is very important in driving what we're going to do for the patient. It can usually be found under the either the initial patient channel or where you place your vital signs, depending on which version of Pulsera have. So there's that. After you guys come and bring the patient into the ED, you're going to stop at our stroke bay. Our EMA providers in the ED are going to meet you there. You guys give a report. You know this process. You do it all the time. My hope, and based off of what Dr. Sanchez has said in his, is we're trying to get as many hands in the pot as early as possible. So Dr. Sanchez is great because he's my only provider that actually comes on early in the case when you guys send that straight through. A lot of times my providers don't want to get involved until after they come back from CT because we were so short-staffed. We did not have enough neurologists on board. We had 2 for an entire hospital. Now I have 6. So things are changing. My plan and my want is we can get them on the case earlier so they can have access to the chart sooner. They can start seeing what's going on with the patient. In that regard, though, there is something that we are trying to bring into Pulsera so that those physicians have the ability to reach out to families. We're looking for next of kin information. We're looking for POA information. I know it's another piece of information to write down and another part, really going to do more paperwork, but our hope and our goal is if we can get everybody on the same page in the same book earlier, the better. Meaning, if it's going to be an intervention case because your lens is a 4 or a 5, Dr. Sanchez is on call. He has that phone number that he can call that family and say, "Hi, my name is. I work at Peace Health. It seems like your family member is having a stroke. These are the symptoms that we're seeing. If worst case scenario happens and we need to take this patient to the cath lab, I need to obtain your consent." And you can do that ahead of time while you guys are driving in. So when that patient rolls in through the ED, they stop at my stroke bay, I can finish getting that 12 lead. I can get those 2 IVs. We can go to the scanner and then we can head to the cath lab and we can hopefully get them into that cath lab suite and that clot out of their brain in under 60 minutes of time. That is the ultimate goal. Also, same with clot busting medications. If we're going to give somebody TNK and they have, a contraindication because they're on a blood thinner or they've had a fall and they've had a recent surgery, if my neurologist has the ability to reach out to a family member that knows the history better than the patient does, there's an easier chance of completing that checklist, and we can actually give that TNK in the scanner. That is standard at most primary plus stroke centers and comprehensive stroke centers across the country. We should be giving those medications in the scanner. And I know you guys like to see what happens to your patients. Wouldn't it be really cool to actually see an intervention done in the scanner and you actually see your patients wake up and you saw them on the ground almost dead? How cool would that be, right? So that's why we're trying to grab those pieces of information into Pulsera so we can hopefully expedite those interventions. In terms of the hemorrhagic side of things, well, here, let's finish neurointerventional things first. This is the other portion of this. Essentially, after you guys bring the patient into the stroke bay, the ED physician evaluates the patient, places CT orders, we go to CT. Based on results, they call neurology. Neurology comes to assess the patient. If neurology thinks that the patient needs to be seen by a neurointerventionalist like Dr. Sanchez. They'll activate them, and then we'll make some decisions if we're going to go to the cath lab or not. The plan with Pulsera is hopefully to streamline that process. And that's what the end of this diagram says when they toggle that LVO button at the bottom. I don't know if you guys can see it on your side when you're putting your stuff into Pulsera. Do you guys see the LVO portion?
Typically it's handled by AMR.
AMR, they do all that stuff. Okay, cool. I don't know what you guys can see a lot of the time, and the reason why I like having this conversation is because Pulsera does have the ability when we get to the end of these cases where we revascularize in the brain, we can put all that information into Pulsera and it becomes a closed feedback loop for all of us. So if you were the medic that was on the case and you're the one that saw the patient first, we have the ability of putting all that stuff into Pulsera once it's closed, and you can go back and you can see the case from start to finish. So you actually know what happens to your patient in real time. Wouldn't that be nice?
Is that standard practice yet?
It's in Washington, no. But that's something, like I said, if I can get all the players involved, right? If I can get my neurologist on time, if I can get the ED charge nurse to be putting the information in real time, if I can get registration to do what they need to be doing, by the end of everything, we should be able to get you guys something within Pulsera so you can see it in real time.
And so it's for your background. So right now, the first response agencies do not have Pulsera, and it's only the transporting agencies that have it. We're exploring whether we can do that. But like I was saying before, I'm not going to create a dual documentation burden. It needs to integrate with the ESO, and it needs to be a smooth workflow. That's why we're trialing it before we would consider rolling out to everyone.
And that's all we're trying to figure out too, right? Whether it's between you guys, my teams, my neurologists, we're trying to find something that works for everybody to make sure that everybody gets the piece of the pie that they really want. So the next portion, obviously what happens next, we have the ischemic stroke pathway, the hemorrhagic pathway. Ischemic pathway, we talked about either going for a thrombectomy or giving them that TNK medication. That decision is made by the neurologist. So getting the patient to the ED, getting neurology to see them the fastest, they're the ones who are going to make the decision. Anybody else who makes that choice, we're calling in a cath lab team. It's very expensive. Hospitals get mad, especially at me, but we do what we need to do. After they receive whatever intervention, whether they get a TNK dose or they go for a cath lab procedure, they're going to be admitted to one of our stroke specific units. Most of the time it's the neuro ICU, where they'll be monitored every hour with an NHSS. And then after that 24 to 48 hour period, they're usually downgraded to like a neuro floor where our stroke certified nurses take care of them. Who knows anything about NIHSS? You guys don't use NIH in the field, I know that. Does anybody know anything about the scale? It's long scale, it's convoluted. It's something that was actually developed as a research tool, not necessarily a clinical tool. The reason I think it's significant, I want to tell you guys about it, because obviously when you're doing like a BFAST or a LAMS, you're encompassing a small amount of stroke presentation. Same for us. NIHSS doesn't pick up a posterior stroke. So that's why it's really important to try and get patients to the EAD as quick as possible so we can get them into the scanners, we can figure out what's going on. For our hemorrhagic strokes, again, we're going for that non-con CT to rule out a head bleed. If we have that head bleed, either our CT techs or our EDRNs are going to call the ED physicians and give them a heads up. Obviously, we're not qualified to read, but I can say, hey, there's a big white blob in the middle of the scan, so you might want to call the neurosurgeon. From that point, they're going to call neurosurgery, and then neurosurgery is going to evaluate the patient's physical exam and their imaging to see if there are any appropriate interventions. Dr. Sanchez had mentioned doing the hemicraniectomy, which is usually the most like dire one if you've got that brainstem compression and they're going to herniate. Other options that we can use medications like mannitol, 3%. Something that I'm trying to develop at PCEP in our ICUs is to see if we can use a higher percentage of sodium chloride, a 23% sodium chloride trip, or a push, which would be a lot more substantial for our patients that are in that like emergency zone without having to take them to surgery, which would be a nice bridge. And then either doing a burn hole or an EVD or a brain drain is what I like to call them. If we can get a drain into the ventricles to actually decrease some of the hydrocephalus of the edema in their brain, they may have a better chance of survival. So. And then the last thing I wanted to talk to you guys about, because we have all these great interventions that we use, how do we determine who gets them? A lot of times your guys' LAMS, my NIHSS, their history, their exam, those are all the obvious things. But the one that a lot of people don't know about is the modified Rankin score. This is a score that evaluates a patient's disability from home. And we're looking to see if we were to do this intervention and get them back to their baseline, is it going to be fruitful for them to return to some sort of quality of life? Scales from 0 to 6, 0 being perfectly back to normal, no problems, they have no deficits whatsoever, 6 being dead. A lot of times, patients, after they've had strokes in the past, exist in like the 2 to 4 range. So they'll be able to still get around the house, but they may have some cognitive deficits or speech deficits, and they're not able to fully communicate the right way. Some patients, they lose their ability to, do the bills, drive to the bank, any of those like modern, like cook their own meals, stuff like that. Then you get into the physical disabilities, which is the 3, 4, 5. They're not able to walk on their own. They need total care for their ADLs where they're completely bedbound. Usually when you hit the 3, 4, 5 territory, that's when we really start having critical conversations. Are these interventions going to be fruitful for these patients in the long run? Is the risk worth the benefit? A lot of times this score is going to drive whether those patients are going to go for that thrombectomy, that heavy craniectomy, things of that nature.
If I could, so from the EMS perspective, like we don't need to know this scale, but just plain English, what does the patient do every day? Like bed bound, wheelchair bound, walking ambulance with a walker, just plain English, what's their level of function?
That's all I have. Ta-da.
Thank
Just some quick adverts to Dr. Sanchez's presentation. Do you guys have any questions? Yeah, go for it.
If you don't have a next of kin or POA, or what do you guys do?
Ugh.
So you need two physician consent, where we both document that we can't reach someone and that we both think it's in the patient's best interest. So if it's a young patient that's out for a run, has no wallet, no contact information, has a severe stroke, they're definitely going to get an intervention via that pathway. We might maybe look harder if it's somebody in their 80s and question what dementia, or they're coming from a nursing home. We're probably not going to intervene on that patient.
And that's the hard part. Even if we do get them to a point where they do receive an intervention, you'll see patients sometimes in the hospital for 2, 3, 4 months waiting for guardianship, for future placement in general. And even if they do have a guardian, they come back in, I have to call that guardian for any sort of medical intervention the second, the third, the fourth time, which is why conversations, palliative care, comfort care, the whole gambit is important. And which is why we want those phone numbers ahead of time, so we can reach out to those poor people as early as we can to make sure that we're making the right decisions for those patients. So.
Yeah, I think the most disheartening thing is to do an intervention. Patient did very well, and the family says, "Oh, they don't want to feed me tube, so let's withdraw care, put them on comfort care." And we just wasted all these resources trying to help them. So it is vital.
Thanks.
Okay. Thank you. Thank you.
All right. Good morning. My name is Christy Idem. I'm the stroke coordinator at Salmon Creek. So I'm going to go over some just basic data from patients that have been brought to our stroke center. And then we're going to go over some case reviews and just try to pick up some high points of patients that have brought in recently. Sometimes I see trends, it's like one day every patient that comes in is, a bleed, and the next day it's all ischemic stroke. So we're going to go over some of those and some key things that I pulled out of those cases that maybe you guys could focus on. Some of them are just learning opportunities for us of how to kind of suss out what those patients look like. So just an overview of what our stroke patient population that EMS bring to us. We break out and report all of our stroke patients by stroke type. Our ischemic or acute ischemic stroke, which is the purple section, by and large, are the majority of our patients that come in both by EMS and our walk-ins. Those volumes pretty much stay pretty consistent. We have a little bit of variation, usually by a couple percentages, is about the only difference with that. Our bleed population, the blue and the green, combined with both our intracranial hemorrhages as well as our subarachnoids, and then TIAs are kind of just the catch-all rest of the population for us. So again, not significant differences with who walks in and you guys bring in. Just going over some Pulsera data from patients that you guys bring in. For Salmon Creek, we use Pulsera in a very different fashion than Peace Health does. We don't, because we don't do neuro interventions, we don't enter any of that end user data that you guys would be able to see. And since you guys aren't utilizing that anyway, But we still do use it as our primary notification system. And so I can get in and pull, you know, how many patients came in as stroke alerts and how many patients came in with some other chief complaint that then we ruled them in as a stroke. So that's not uncommon. So just by month to month, not super important. We won't spend a lot of time in each one of these. But like, for instance, in August, you can see we had 8 patients that came in by stroke alert that had that pre-activation. 5 of them actually ruled in as strokes or TIAs. 3 of them ruled out. And then we had 4 patients that came in that did rule in as a stroke, but came in kind of with just an altered mental status, symptoms over 24 hours. So it didn't meet criteria in any of these cases for a field activation. So all were appropriate. We had some patients that, you know, symptoms have resolved. That's not uncommon. We did not have any large vessel occlusions last month, and we did not have any hemorrhagic strokes that came in last month. We had 1 patient that declined TNK, no thrombectomies. As far as alert systems, you can see with the triage categories that were utilized in Pulsera. Again, I won't spend much time on those. We did have a few that were not categorized. Some of these are older. Again, the trends kind of stay the same. You know, as far as activations that we get pre-hospital that come in June, we had 9 activations, 5 patients that actually ruled in, 4 that ruled out, and then another about similar volume that came in with seizure-like activity, transient symptoms, other symptoms to be concerned about. 1 that was a posterior circulation concern, dizzy, vomiting, again, negative stroke screen. So you guys are doing the stroke screens appropriately. So didn't meet activation criteria. That particular month, we did have a couple bleeds that came in. Again, really didn't meet any criteria, and we had a couple large vessel occlusions. So we'll just go through these pretty quick. So I want to be able to go through the case reviews and spend a little bit more time with you. April, with 7 activations, 5 of which, or I'm sorry, 5 that came in with a stroke activation. We do have, we've had a couple, we actually had 1 recently that was in September, but 1 in April also. Found down, not an uncommon presentation. We do, and I have a case review in here. Those found downs, obviously there can be a multiple reasons that they were found down, but we do sometimes see in those cases, and we've had, like I said, 2 recently, that they're either large vessel occlusions, basilar occlusions. They don't do very well. They look really bad. We scan them and discover that, and then have to like kind of prognosticate and decide what we're going to do with them. We're going to talk a little bit about screening tools. Dr. Ford is our stroke program medical director for Legacy System. She's online. She wasn't able to come up because she has to be at a manual today. So she's going to discuss the 2 screening tools that we utilize in our area, as well as the hospital. We use BFAST. I know you guys use BFAST too. I do look for that documentation when a patient comes in with stroke symptoms and either rolls in or comes in as a stroke activation. And I do retrospective chart reviews just to make sure we're not missing any opportunities. And so I'll let Dr. Ford take over with discussing those screening tools.
Hi guys, nice to talk to you this morning. Can you all hear me okay?
We can.
Hopefully. Thank you. So I will just go over some brief information here. We all know in stroke care, minutes matter. We want accurate and quick screening tools. We know that patients who are treated within 60 minutes, really the golden hour of stroke, have better outcomes, lower in-hospital mortality, and reduce long-term disability. Benefit of treatments persists for longer than that first hour, but it really does make a difference. And we know that quicker treatments add healthy days to a patient's life. This is all extrapolated based off of how many neurons per minute die, but looking at 15 minutes faster treatment may lead to a month of healthy living for the patient. You guys know the BFAST and LAM screening tools, so I'll just go over them very briefly. BFAST stands for balance, eyes, face, arms, speech, and time. And the Clark County protocol is to transport any patient with a positive BFAST finding within 24 hours as acuity red, as well as notify the receiving facility of the stroke alert. When we talk about why we utilize this, you know, it's a redevelopment of a prior tool, the FAST tool, which is what's taught to the lay population. FAST identifies a high proportion of strokes, but it does miss many posterior circulation events. And that's because FAST, face, arms, speech, and time doesn't include balance and eyes. So it doesn't really assess for the cerebellum or the brainstem. So the addition of the BE, balance and eyes, improves identification, but it's a little bit more challenging. Ataxia or balance is difficult to quantify, especially when you are moving quickly and in the field. That being said, there are multiple reviews, studies, and this meta-analysis of over 6,000 acute stroke patients showed it had a better sensitivity and specificity. And we can see that as the score goes up, the sensitivity does go down, but the specificity, meaning the accuracy of selecting specifically for stroke, goes up. Talking about LAMS, which is facial droop, arm drift, and grip strength, really desired because it is very easy to use and quick. We know that the Clark County protocol is to transport any patient with a LAMS of 4 or 5, essentially any positive, to an intervention-ready facility, Peace Health Southwest, or a comprehensive stroke center in Oregon, including Emmanuel, Prov Portland, Kaiser Sunnyside, or OHSU if neuro-IR is unavailable at Peace Health. LAMS is a pretty good test. It's not perfect, but none of our tests are. So originally validated in just under 100 patients, there was a decent mimic rate of 5%, but in the patients who had acute cerebral ischemia, nearly or just above half of them had a large vessel occlusion, hemorrhage in another 19%, and really showed that LAMS with a cutoff of above 4 showed good accuracy. Sensitivity of 0.76 for LVO and specificity of 0.65. And we can see the detection for LVOs at the different scores in that initial study. A limitation of the LAMS score is right in the name. It's pure motor. It does not look at vision or language. And we do know, both instinctually as well as factually, that you can have a stroke that doesn't have any motor involvement. Certainly you can have a patient who just has vision loss. You can have a patient who has vision loss and balance problems without having motor deficits. But the screening tool looking for large vessel occlusions, specifically looking at the anterior circulation, is pretty good. Talking about the most, in my opinion, most challenging type of stroke, posterior circulation, it's not rare. It happens about 20% of ischemic stroke cases, but the misses are by far much more common for posterior circulation. Delayed recognition or missed in up to 60% of the time. That's almost 2 out of 3. And it's because many of our stroke tools are poorly assess the symptoms of posterior circulation stroke. So what are these key symptoms? Constant dizziness, not dizziness that comes when you move your head quickly and goes away, but constant. It can get worse with movement, but it should be there in the background. Specifically nausea or vomiting, especially if it's persistent nausea and vomiting. Cognitive changes or level of consciousness changes, vision changes, and then gait, balance, ataxia, those kinds of things. I did want to point out, despite the fact that we all think of basilar occlusion being the unconscious, rapid syncope and then unresponsive patient, disturbed consciousness is not highly specific for posterior circulation stroke. There's a lot of things that make people unconscious or drowsy or obtunded. That's not to say stroke's not on the list. It's just not the only thing on the list. When we think about our assessment tools, we do want to think about a couple of key things. And as you might guess, BE, balance and eyes, is on this list. So first we think about gaze. Is there a deviation or paralysis in the eye movements? Is there a disconjugate gaze? Are the eyes going wonky? Especially this is a new phenomena. Do they have visual changes like a visual field cut, blurry or double vision? Do they have incoordination, dysmetria on finger to nose or heel to shin, truncal ataxia when they're sitting, or gait instability? Can they walk? Do they fall over? Are they wide-based? Do they kind of lean to one side? They kind of walk in a crooked or curved pattern? Versus are they equally off balanced? That curved pattern may be because of weakness versus equally off balance. You know, they just can't be correct. Almost imagine that we've had too much to drink. That is a problem in the cerebellar function. That the ataxic, like I was suddenly drunk, is a sign that something's not working back in the back of our brains. Not that I penalize anyone, including neurologists, but cross symptoms, specifically thinking of one side being weak, another side being numb, or having, say, one side of the face and the other side of the body. Those are very specific and point to the brainstem. So if you ever see a patient who sudden onset, they've got nausea, they've got dizziness, also they've got this weird wonky pattern of weakness or numbness, that doesn't necessarily mean that patient is faking or having something weird. That may actually be a stroke involving their brainstem. We'll jump to case reviews next. Christy, you want me to jump in?
So first, Dr. Ford, thank you. That was a great review of PFAS and LAMs. I just want to point out a couple of things. This is hard. You know, I know I've missed these in the emergency department. The key things that I would think about from the EMS perspective, what often gets missed is that you see the patient in a natural environment and you see how well they can walk or not. And then if they get loaded on a gurney and then they get lifted over to the gurney and ED, we may miss that they all of a sudden lost balance. So if you're like needing to bust out a stair chair, a mega mover, if you're hurting because you had to hold the patient up, think about that like, okay, think about that as a positive beat, like they've lost their balance, they've lost their ability to walk. If you're having to do the work of getting the patient around, then think about what's happened to the patient's balance. And then the second thing, talk about fan down. You see tons of patients fan down. You know, stroke literally comes from as if someone was struck down by God. And so if it's either sudden or you can't prove that it wasn't sudden, those are the cases that could potentially be stroke, and we often see this. Thank you.
The other thing, just to add on to Dr. Mock's comment about that communication about what you see when you're there and what information you gather from the family, that is really important because sometimes we get that after the fact and sometimes that helps with our decision-making process. As Candace had discussed earlier, that modified Rankin, we utilize that sometimes as a diagnostic tool to tell us whether or not we're going to intervene on that. So we might ask, do you know what the patient's baseline is? Because you guys might be the only way we can get that if we don't have a family member that's there. You know, hey, we saw a wheelchair at home, so we know that they're wheelchair bound. That's really important information for us early on to really help kind of determine what we're going to do with that patient potentially, or what the degree of that new deficit might be, since that's what we're really looking at. So I grouped these together just by stroke type. So kind of a dead giveaway. I've literally titled them for you. So we know we've got kind of a batch of hemorrhagic strokes that I separated by intracerebral strokes, our subarachnoid strokes, and then our ischemic strokes. Put some pictures in there if we could find some, radiographically important findings. What I tried to pull together was some of the history that was in the EMS charts, both in ESO as well as Pulsera, and then kind of what our findings were in hospital, and then their long-term discharge plan was. Sierra, did you want to present them or do you want me to present them?
Sorry, I'll go ahead. So the first case is an 85-year-old woman who has a history of breast and uterine cancer, chronic kidney disease, and polymyalgia rheumatica. She developed dizziness and bilateral arm tingling, not obvious stroke symptoms in my mind. She had started a new medication for vertigo the previous week, but said it wasn't helping. She was reported to be anxious and tearful about recently losing her spouse. BFAST and LAMS were both negative. So this is a challenging case. Not something that screams stroke, certainly does not scream hemorrhage, really in my mind at all. But she was hypertensive in the field and during transport, and we're saying significantly hypertensive, started at 182/97 and actually went up to 195/100. Her initial neuro assessment in the ED showed weakness, ataxia, and some word finding abnormalities. Again, this didn't scream focal deficit to the ED doc, but they did order imaging. And somewhat surprising, perhaps, there was a pontine hemorrhage found on the non-con CT. So as we can see here, hopefully you can see my cursor. We have this bright white in kind of the center of the brainstem. This is the pons. Yep, in there. And so that location does affect it's in the center, it's going to affect both sides. And that's why we're getting this dizziness and bilateral sensory change. My guess, if we had gone back to our history, is that her dizziness was constant, not an intermittent dizziness that makes us think a peripheral thing, but a constant dizziness that makes us worry about stroke a bit more. In the setting of persistent significant hypertension, hemorrhage is on the etiology, and this was thought to be a hypertensive hemorrhage. She did well, actually, for this location in particular. She was discharged to a SNF 6 days later for rehab.
And the only reason that I pulled this one out in particular was just because of her kind of really generic symptoms. And these are kind of a lot of presentations that we see routinely. And the only thing I want to say is just use caution when, patients report that her anxiety, I think, became everybody's primary focus. And thankfully, she was assessed relatively quickly. But those are the things that we kind of sometimes deviate from what really looking at the patient and assessing them and letting them tell us what's going on and going down a different pathway. So those are sometimes where I see some delays in recognition.
All right, this next case is a 56-year-old gentleman who has a history of hypertension, which unfortunately is untreated. He's a drinker with daily drinking. He reports sudden onset nausea, dizziness, blurred vision, and diaphoresis. He has a near syncopal event when he tries to sit up, and there's a concern for a peri-arrest presentation, so he's transported to the nearest facility as triage level red. BFAST is checked and negative. His GCS is 15. His pupils are 2 bilaterally. His initial pressure is high, 210/160, and he requires both labetalol and a nicardipine drip. He has the CT head that's shown down below. So what we can see is the white in the ventricle. So this black kind of fluid, what is fluid space in the middle of the brain are the ventricles. And we can see a hemorrhage. I don't know if you can see my mouse, but starting in the image on the left, kind of upper left quadrant right there, that's the hemorrhage itself. And that is tracking as we go down the slices in the head, tracking through the third ventricle in the middle slice and down into the fourth ventricle in the the far right slice, which is the lowest slice of the brain. And so this is a spontaneous intraventricular hemorrhage inside the ventricle. And this is, a specific type of intracranial hemorrhage that is higher risk for mortality, because if you don't relieve the if you don't get in there and make sure that that blood doesn't clog up the system, you can actually have hydrocephalus develop, where the fluid just doesn't drain through the natural processes. This patient did, of course, require a higher level of care, and they transferred to Emmanuel for our neurotrauma ICU. Emergently, they did require an extraventricular drain. That's the drain that goes into the ventricles to kind of suck out and relieve some of the pressure. The patient did go on to have hydrocephalus. That's that kind of overaccumulation of spinal fluid in the brain, which increases the pressure. The patient also had a couple other complications. He had cerebral salt wasting, which is a phenomena when your part of your brain that regulates how your salt balance is done gets kind of disrupted. And as a result, you end up with over excretion of over excretion. Oops, sorry. We're both doing the wrong thing. Your salt goes the wrong direction. So your salt levels, your sodium level in your body can go way wonky. And this can actually be a quite serious problem, because the brain needs an even amount of salt. We're like Goldilocks. We don't want to be too salty, but not too pure water either. In spite of all these complications, the patient discharged home, which is kind of amazing, 15 days after presentation, and he had no focal deficits. So these patients, despite their severe course, can do quite well in the long run, but really a serious problem. Our third case, is an 83-year-old woman. She had sudden onset headache and vomiting. Headache is not something we think about with stroke very often, according to the books, but certainly you and I see it in practice in a fair amount of cases. It's one of those things that's common, but is not highly specific, meaning it happens in a lot of people and doesn't always mean stroke. This woman had a history of prior intracranial hemorrhage, hypertension, and atrial fibrillation, and she was not on anticoagulation because of her prior brain bleed. With her sudden headache and vomiting, there was appropriate concern. Her GCS was measured in 15. She was hypertensive, especially her diastolic in the 130s, but her systolic went from about 160 to 200 during transport. Her pupils were fairly normal, and she was brought in as a triage level yellow. I can't fault that. She has nothing focal in her exam. Her BFAST was negative. It was actually done twice. And so again, can't fault it, but this is a concerning case, and I think a yellow level is potentially reasonable. When she arrived at the ED, she did report new double vision, and when kind of looking closely, she had a gaze palsy, meaning her eyes weren't moving normally. She did describe the headache as the worst headache of her life, which is obviously a buzzword, probably for all of us, but worst headache of your life is classically taught to be a subarachnoid hemorrhage. I will say people who have migraine, by definition, will have the worst headache of their life at some point, but typically subarachnoid is sudden onset, very severe. While she was in the ED, she developed a facial droop, started to become drowsy. So we had the CT. What we can see as we go from top to bottom on our images here on the right, kind of in this upper slice, that's fairly normal. There are some very subtle abnormalities, but if you kind of just say that's fairly normal and you look down to the middle slice, we can see there is that white in the center of it, interventricular hemorrhage, kind of about an inch above, Christy, on your mouse. I don't know if you can see mine.
That's interesting. On that slide, it's in a very different position of where it's on here.
Yeah, right there. And then on the lower slide, we can really see there is blood kind of all around the brainstem in front of the pons, and then in the fourth ventricle, which is kind of below the pons. And this is that, very concerning subarachnoid appearance. As I just described, imaging showed subarachnoid hemorrhage with interventricular extension. The CTA was concerning for a right MCA occlusion, and there was active bleeding. Sometimes we can see, because we give contrast in a CTA, you can actually see the contrast leaking where it's not supposed to. And so that put together with the other findings is suggestive of active bleeding. The patient was emergently transferred for higher level of care, and she actually went straight to the cath lab for an emergent angiogram. Luckily, there was no large vessel occlusion on the angiogram. Very complicated case. She also did not have an aneurysm or a vascular malformation found as the cause of her subarachnoid. Before transfer from our facility, she did have multiple episodes of non-sustained VTAC. She was started amiodarone and prophylactic anti-seizure medication. Her course was complicated by hydrocephalus, that lack of appropriate drainage of the fluid, cerebral salt wasting, where the body doesn't regulate sodium appropriately because of brain injury, and then delirium, where just the brain's not working well. Complex course took her 18 days, but again, she was discharged home. So yet another case where, despite how sick they are, they actually go home after this, not just a facility. All right, another subarachnoid case. This is a 33-year-old woman who had given birth at home earlier in the day. So kind of already unusual for our age. Her spouse had witnessed some seizure activity lasting about 2 minutes. She had no history of seizure disorder, and she had a pounding headache. So obviously we're pretty concerned about this young lady. Her eyes are normal. Her GCS is 15, but this case didn't have a stroke screening done. I can kind of understand why. We think she's got a headache and some seizures. She just gave birth, brought in as a triage level yellow. Now, obviously, we're talking about this in a stroke case. She does rule into having a stroke, and as you know from our title, she has a hemorrhage. Her blood pressure is quite high, up to 190/110. Her CT is shown on the right here. So going from top to bottom, we can see on the right side of the image, there's that like kind of faint, wispy, whitish, what I would call linear pattern. That is a subarachnoid hemorrhage tracking into the fluid spaces in the brain. And we can see that kind of as we go from top to bottom, kind of persisting at the different levels. And then as we go to the image that's furthest on the left, we can see that it actually is tracking down around some of the brainstem and the anterior cerebellum. So she was felt to have eclampsia and HELLP syndrome. With her HELLP syndrome, she had low platelets and elevated liver enzymes. And despite these things, She was discharged home 3 days later. So really miraculous, kind of getting her in, getting her evaluated, despite all the potential things that could go wrong. She went home 3 days, blink of time.
And because we don't see a ton of OB patients that turn into stroke patients, it is a big risk factor. So I added some additional education in here for us to just kind of look at. So with our pregnant or postpartum in that kind of higher that higher degree of both ischemic and hemorrhagic strokes. So I just want to make sure that that is something that you're considering if they've got some neuro deficits. We, depending on which resources you look at, that kind of 8 to 12 weeks postpartum or out to that period of time is when they're at highest risk. And so we just want to be looking at some of those. So looking at those patients that are severely hypertensive and managing that. Again, looking for those BFAST symptoms. Are they reporting a headache? Now, obviously, that can be other reasons also, but making sure that we're at least considering that. Because unfortunately, about 40 to 70% of these perinatal cases turn into mortality cases. And so we really don't want to go that direction if we don't have to. And then any female that's on birth control pills puts them at higher risk for ischemic stroke, any hormone replacement therapy, and then in particular, if we have a patient that's got an advanced maternal age, puts them at higher risk.
And that would be greater than 35 years old.
35, yeah, becomes geriatric OB. So anyway, our perinatal stroke patients present just a little bit differently. A lot of them do have headaches, both in the ischemic as well as the hemorrhagic. So that's not common in our non-pregnant patients, especially with the ischemic strokes, don't typically report a headache. They'll often, if they have a migraine, we usually ask, is it different than your typical migraine presentation? And then looking for those focal neurologic deficits. So again, doing your BFAST screens with those patients. There's a little acronym that the obstetrical world uses that it's called SCAN-ME. So it's just reminders of these high-risk patients if they are reporting headaches, some additional things to ask. You know, is this a sudden onset? Have they had a seizure? Again, that's a big risk for these patients. Does the change in decision or quality make any difference with that? Are they, do they have altered mental status? Again, could be other things, but we're just needing to consider those. Any specific neurologic deficits, nausea or vomiting, and then with medications, have they tried something at home and it didn't help at all? And then that E is looking for the elevated blood pressure and temperature. So when we see those really hypertensive patients higher on our threshold of suspicion. There are some additional symptoms, again, seizures, that extremity weakness, so BFAST symptoms, dizziness, as long as we're doing that balance, nausea, behavioral changes is kind of a nondescript one. And then neck pain, and that's not specific to perinatal patients, but we're really looking at our dissections of our carotids and our vertebral arteries, which can lead to strokes. Patients do often report neck pain with those.
All right.
We can't start in time.
Okay.
So we have to finish by 10:30.
Okay, we can skip that one. I'm trying to think. I've got trying to think if there were any of these that I really wanted to go over, and not necessarily. Sarah, out of the last two, I'll skip the last subarachnoid. I don't know. We can just do high level overview because we're like out of time. So
yeah, I think this case was fairly interesting. Focusing on this 58-year-old man with risk factors, he had sudden onset confusion, garbled speech, repetitive speech. He kept saying, I can't see. His BFAST was positive, but his LAMS was negative. He was, of course, brought in as triage level red as a code stroke alert. His exam did show a gaze palsy. So again, thinking about the eyes, left-sided weakness, and severe aphasia. And so I think one of the challenges that I wanted to talk about here was the challenge between confusion and aphasia. So obviously confusion can be from anything. Aphasia is more typically from a brain abnormality on the left side of your brain in about 90% of cases. And that difficulty with understanding is the receptive aphasia. It can't go in. The difficulty with expressing yourself, the words not coming out or coming out kind of wrong, is that expressive. And if you have both of those, that's global. The other reason I wanted to talk about this case was because he had thrombolytic. He was given tenecteplase. His CTA showed an M2 occlusion. He was emergently transferred, but he actually got significantly better after thrombolytic before thrombectomy. And when he got to thrombectomy in the angio suite, they found there was no clot left. It had completely dissolved. And so another amazing case, discharged 2 days later, complete neurologic recovery. So what we do is hard, but we really do make a difference in our patients' lives. I want to thank you guys. I recognize in the field is especially challenging. I get to cheat and already have all of the data you collected, but really getting our patients to the right facility, getting them the care they need. Thank you for what you do.
Anybody have any questions for either of us?
And so just to wrap up, I just want to say thank you to all the presenters. Thank you, Dr. Ford. I just really, really appreciate getting all this expertise together. From the EMS perspective, this is hard. When I started my career in EMS, if there was a patient that had a stroke, for the most part, they would get an aspirin in the hospital and get rehab. And so this challenge being put on us, the EMS world, because there's so much more that we have to offer stroke patients now than we used to. And particularly all the neurointerventional techniques have really changed what we can offer. And so that puts the pressure on us in the EMS world. But we get an opportunity to help our patients by identifying stroke. The key thing is to think about it, especially in these situations where we wouldn't typically, for example, the pregnant woman, the person with the sudden loss of balance. I want to just make sure that I clarify any misconceptions. The fact that Legacy Salmon Creek can see STEMI patients does not change their stroke designation. So Legacy Salmon Creek is a primary stroke center. PCL Southwest is a comprehensive stroke center. And so for patients with LAMS 4 or 5, or otherwise meet the designation for a comprehensive stroke center, those patients still go to PCL. That's all I have. I really appreciate your time and attention and what you do. Thank you.
Thank you.
Thank you all.
Okay.